Exciting things are on the horizon for people living with chronic spontaneous urticaria. Today, we're diving into the new treatments that are set to revolutionize CSU care. In this episode, we unpack what drugs are coming up and how they work with the mast cells to alleviate hives. This episode is made in partnership with the Allergy and Asthma Network, and we want to thank Novartis for sponsoring this episode. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology.
Today, we are going to talk about emerging therapies and treatments for chronic spontaneous urticaria. And we have a special guest, Dr. Zirwas, who is a dermatologist. And Dr. Zirwas, can you just give us a brief introduction into who you are and where you work and a little bit about yourself?
Yep. So I'm a dermatologist in Columbus, Ohio. I trained at the University of Pittsburgh and did undergrad med school residency, my first faculty job there. Then I came to the Ohio State University and was the dermatology residency director for about 10 years. Now I'm in practice and primarily do clinical trials. My main interest for the last 20 years has been itch, eczema, and urticaria. So I have much more of an interest in urticaria than most dermatologists because I do take care of a significant number of urticaria patients.
Great, thank you. How do you approach the management of CSU in patients who have not responded to standard treatments? And what promising options do you think are coming out and available for these patients? So I think first, let's just talk about how do you manage patients with CSU, and then when do you start thinking about other options?
The first thing with CSU for me is really a good explanation for the patients. And I'm a huge believer in analogies, that they are by far the most effective way to explain complex topics in an understandable, retainable way. And so when a patient comes in with urticaria, CSU, the first thing is we have to get them to understand that it's not an allergy, that there isn't anything we're going to identify. It's nothing they're breathing. It's nothing they're eating. It's nothing they're being exposed to. And so we have to get that point across that this is much more of an autoimmune disease. The way that I tend to explain urticaria sort of goes like this. So, patient comes in, it's generally an easy diagnosis. You look at them, that looks like a hive. If they don't have any hives while they're there, they almost always have pictures on their phone. So you look at the pictures on their phone. Okay, so how long has it been going on? Oh, it's been going on for 6 weeks. Okay, that tells me that it's chronic urticaria. And so then I go into my spiel, which starts with, so this is a really interesting thing because most people, whenever they get hives, you think allergy. So you assume that there must be something you're allergic to. But it turns out that once somebody's had this pretty consistently for 6 weeks, we know that it's incredibly unlikely that there's anything they're allergic to. It much more is a problem with the immune system. And that really becomes a challenge. And so here's how we think about this. Your body is filled with these things called mast cells, M-A-S-T, mast cells. And you can imagine these mast cells as being tiny little water balloons that are microscopic, that are all over your skin. They're in your eyes, they're in your mouth, your throat, your lungs. In these mast cells, these little water balloons, instead of being filled with water, they're filled with histamine. And histamine makes you get itchy, sneezy, gives you welts, all the things that you would take an antihistamine for. And so what happens in the normal situation is you can imagine things that you're allergic to as being like little needles, that whenever you get exposed to them, now your system is flooded with little needles that pop your water balloons. And so then your water balloons, when they pop, the histamine comes out, you get hot. So in you, there's something else going on. So one way that people can get this is their water balloons get too fragile. So it doesn't even take a needle to pop them. It's just if they get cold or they get pushed on or they get hot, that might make them pop. So they just become more fragile. What I'm talking about now are chronic inducible urticarias, which are a slightly different thing from CSU. But so that, I describe, okay, the water balloons are too fragile. But that's not what's going on with you. It's not a problem where your water balloons are too fragile. With what you've got, this chronic spontaneous urticaria, what's actually happening is your body is either making its own needles. So you're actually allergic to something your body is producing, or your body is actually pulling the needles in. So even though you don't really have much in the way of these needles, your body is actually pulling them towards the little water balloons and causing them to pop. And there's no way with either of those two to get you better by changing what you're being exposed to, because in the normal situation, if you had an allergy, we try and get you away from the needles. Well, we can't get you away from the needles that are popping your water balloons because they're coming from inside. And so instead, what we need to do is try and treat you. And the first thing that we do is we try these medications, antihistamines. Now, you're not going to take like Benadryl, or there's one called hydroxyzine. Those have too many side effects and make people too sleepy. We're going to have you take either Allegra or the generic of Allegra called fexofenadine, or there's Claritin, the generic is loratadine, or there's Zyrtec, the generic is cetirizine. But we're going to give you a really high dose. So the normal dose of any of those is 1 pill a day. You're going to take 4 a day. And now I know you would say, oh my gosh, am I going to get side effects? And no, those medications, if the cetirizine or Zyrtec, take 4 a day of that, there's probably a 50-50 chance you're going to get some sleepiness from it. But the other two, the Claritin, i.e. loratadine, or the Allegra, i.e. fexofenadine, you could take 20 a day and you wouldn't get sleep. You wouldn't have any side effects. It's just that once you get to 4 a day, if that isn't working, then taking 10, 20, 50 a day, if the 4 didn't work, 50 is not going to work. So first we're going to try that. And with that, your water balloons are still getting popped. The needles are still there, but we're trying to block the histamine that comes out whenever it pops so that it doesn't make you itchy and get the welts. Now, if that doesn't work, then we're going to go on to other treatments. And we've got one right now. It's called Xolair or omalizumab. And really the way that we think of that one working, it either sucks up the needles so that the needles can't get to the water balloons, or it's on the water balloons and blocking the needles from getting to the water balloons. Going back to the actual medical way that things work, omalizumab works by binding to IgE. So IgE is an antibody. It's something that your immune system makes, and it binds to things. It really is kind of the needle, but it needs activated by something. So whenever something you're allergic to, the IgE binds to it, that activates it, turns it into the needle, and then it comes and pops. Well, the Xolair is binding to the IgE so that it can't act like the needle. Or it's on the surface of the mast cells, kind of forming a little protective coating to keep the needles out. Now, that's a very simplistic and questionably accurate description of how Xolair omalizumab works, but it's close enough, right? It's accurate enough. It makes it really understandable for people that, okay, this medication isn't weakening your immune system or doing anything toxic. It's just preventing the needles from being able to pop the mast cells, right? So it's directed at the needles. And so now the challenge becomes probably, and we say that anywhere from 50 to 75% of people with CSU will be adequately controlled with the antihistamines. And then for the people who aren't, we say that about 2/3 of them will be pretty well controlled on the Xolair. But that leaves a fair number of people who still are not adequately controlled. And that's where it's now getting exciting. So it was exciting 10, 15 years ago whenever we got Xolair. Not a lot has happened since then. Now we've got some new stuff that's going to be coming. And that kind of what's exciting in the CSU world at this point.
Great. Thank you. I love that explanation. We've had multiple episodes on CSU, and I think every guest that we have has like a nice explanation of how they explain CSU to patients. So I'm happy that we've got all of these different variations for patients and even for providers to listen to and think about how they might be presenting it to people. And so you mentioned that there's some really exciting key players that are coming into the market. Can you talk about some of these?
Sure. So there are 3 of them that are close, right? That we expect to be able to use soon. One of them we expected to be able to use last year, but when we found out that it didn't work in people who had previously failed Xolair, then the FDA said, well, we want more data before we're going to approve this. So first, that one is Dupixent or Dupilumab. It's already available. We've been prescribing it since 2017 for things like asthma and eczema and bad sinuses, even GI allergies in the GI tract now. But that's going to hopefully be available either this year or next year for CSU. Now, how that one works, and we're going to talk about 3 different drugs that are coming, and they each work in a very different way. And that's really important for patients to understand, because if drug A doesn't work, if drug B works the same way drug A works, then you kind of think, well, drug B is probably not going to work either. So it's really nice whenever we have drugs that work in different ways. And so Dupilumab, it's the one that it's hardest to understand. It was iffy. We didn't know if it would work in urticaria or not, because what Dupilumab really does, there's 3 different types of inflammation in your body, right? There's type 1, type 2, and type 3, and allergies are type 2 inflammation. And these mast cells, the water balloons, are in that pathway. And Dupilumab really just turns down type 2 inflammation in general. And so we didn't know, we're in this situation where we've got little needles popping the water balloons, that's just turning down the type of inflammation that the mast cells are in. Was that going to help? And it turns out it does. Data that we have on Dupilumab so far says that for somebody who's not been on Xolair before, works just about as well. So both of them probably get about 2/3 of people to doing really well. The downside of the Dupilumab is that it's slower than the Xolair. So I think of it as being the Xolair typically starts working in about a month or 2. The Dupilumab looks like it probably takes 2, 3, 4 months before it really brings that immune response down enough. So we think of the Dupilumab, right, as working by just reducing that type 2 immunity. Takes a while to working on the mast cells, but it is a really good option for people because it's a little bit easier to take it sometimes, even though it's an injection twice a month as opposed to Xolair that's once a month. The Xolair, a lot of people have to come into the office, at least for the first 3 shots, to get the injections. And in some places, they still come into the office once a month. Whereas the Dupilumab, they only have to come in once a year to get a refill, and they give themselves the shots at home. So that's number 1. Dupilumab is the first new one we expect. The next one that we expect to be coming not long after the Dupilumab is called Remibrutinib. Now, this is super, super exciting because it works completely differently from either of the other 2 that we're talking about, which we could think of the first 2, the Xolair and the Dupilumab, as working from outside the mast cells. Well, the Remibrutinib works inside the mast cells, and essentially what it does is protect them from getting popped. So the needles still hit, but they hit, and you can think of them as bouncing off, right? Now, that's not really what's happening, right? So inside the cell, what happens is you think of it as the needle hits the cell, and then a whole pathway happens inside that causes the pop. Well, the Remibrutinib, it blocks that pathway. So the needle still sticks to the outside, but it doesn't make the mast cell pop. Now, what is super exciting, number 1, it works whether Xolair worked or not. So if you're a Xolair failure, the Remibrutinib still works just as well as somebody who we don't know if the Xolair would have worked or not. Number 2, that it is so fast. So we talked about that the Xolair typically starts to work usually in a month or 2. Well, the Remibrutinib typically starts working in days, maybe a week, but it's really, really fast in terms of how well it works. And then it's a pill. So you only have to take a pill every day. You don't need to give yourself any shots. Now, with all medications, we always talk about, right, the safety and the efficacy. And so with the Xolair, it's a very safe medication. With the Dupilumab, it's a very safe medication. And so it's important that the Remibrutinib is also a very safe medication, and it is. So the only real side effect that's been seen with it have been what are called petechiae. And petechiae, you think of as tiny little red dots. They are totally harmless. It really is just something that a patient might see these tiny little red dots and be like, what the heck is that? But they don't itch, they don't hurt, they're not dangerous, they're not an indicator of something bad going on inside. So the Remibrutinib is a very, very safe medication as well. And the other thing that's exciting about the Remibrutinib, it may actually be something that ends up being an amazing treatment for allergies as well. So by the way that it works of preventing the needles from popping the cells, that should work in regular allergies. There's a chance it could work in asthma. There's a chance it could work in something called eosinophilic esophagitis. So we don't know if it will work in any of those things. The studies haven't been done, but it could work in a bunch of other things too.
Just to recap Remibrutinib, which is one of the names I like saying because it's not so hard.
Yes.
So if I understand, we've got the mast cell, and the Remibrutinib works within the mast cell to basically make it stronger from the inside. If I'm using your needle analogy, what I'm thinking of is it's the needle is coming and something is happening within the mast cell that's not letting it penetrate from the inside.
That is not exactly right, but from the analogy perspective and explaining it to a patient, yes. So the needle is still poking, but when it's poking, it's not popping.
Okay.
In my analogy setting, I think of it as being that the remibrutinib makes the mast cell, makes the water balloon, makes it thicker and tougher so that the needle hits, but doesn't, it sticks, but it doesn't pop, is how I think of the remibrutinib is working.
And I know from another podcast episode we've done on mast cell disease where we talked about Remibrutinib, not so much in detail, but it was called a BTK inhibitor. Can you explain that to us a little bit more?
Yeah, and that's actually a really important thing. So BTK stands for Bruton's tyrosine kinase. So tyrosine kinases are proteins that are inside of our cells, and they in general do something called phosphorylating or dephosphorylating, and thereby activating other things. So you think of these as proteins that do something to other substances. Part of what's important to understand about remibrutinib, so these Bruton tyrosine kinase inhibitors, BTK inhibitors, have been around for a while, but initially they were used as cancer treatments. Now, the problem with them was that they were sort of broad spectrum. So they didn't bind to just the Bruton tyrosine kinase that we wanted. They attached and affected other things, and that caused a lot of side effects, especially related to bleeding and things like that. And so for physicians and providers who haven't really kept up on remibrutinib, a lot of times whenever they hear that it's a BTK inhibitor, they're like, oh my God, those BTK inhibitors, those are cancer drugs and they have a lot of side effects, right? And yes, that is true. But this is the way that I think of it as a next generation BTK inhibitor. And so it is much more targeted, much more specific. Thereby, it doesn't have the side effects of other BTK inhibitors. And so it's going to be really important that providers understand that remibrutinib, the next generation BTK inhibitor, it's more specific, it's more targeted, and so it doesn't have the what I would call the collateral damage of the old BTK inhibitors. And it's really important that providers and patients know that so that it get used appropriately.
Could you just explain the BTK inhibitors?
Yep. And so, it's whenever I phrase it that the BTK inhibitors make the mast cells tougher or makes them less likely to pop, it becomes an interesting question. Well, how are they doing that, right? How are they making that happen? It requires a little bit of thinking through what the pathway is for the mast cells to pop. And so what happens, there's a little protein called a receptor, right, that sits on the surface of the mast cell. And normally IgE, one of those antibodies we talked about, is sitting in that receptor. When something binds to the IgE, that brings two of those receptors next to each other. And then that is how the inside of the cell now knows that outside of the cell something is happening, because that's the receptor's job, is to take that outside and get the message inside the cell. So it brings those two receptors next to each other, and they then start the activation of a whole cascade of events. And then it has to go through multiple steps with one protein activating the next in order to get to where we activate the protein that finally pops the mast cell. And so the BTK inhibitor, the Bruton tyrosine kinase, is one of the proteins in that pathway, where it's A activates B, B activates C, C activates D. The BTK is one of those steps. We really could block any of those steps. It would stop the whole pathway. But the one that we have found that we can block without causing other problems in the body is the BTK.
From the patient perspective, like what I understood is that you've got like this chain of events that happens before the mast cell releases the histamine, right? Like the end result is
Yes.
the release of histamine. And so the needle comes and pokes something, and that poking has this knock on effect where the endpoint is boom, release of histamine. So the needle pokes the water balloon, and then at some point, something in that chain before the explosion happens gets blocked. And that's what the Remibrutinib is doing, right? So Remibrutinib
Yes.
is basically taking one of the links from the chain that will cause the histamine to release.
That's a really good way to put it, that it's taking one of the links of the chain out. And that's what is so different because, right, the other Xolair is trying to prevent the needle from getting there in the first place. But one needle gets in, that's enough to pop your mast cell. So that's why Xolair doesn't work in everybody. So the Xolair is trying to prevent the needle from getting there. The Dupixent, as I said, we're not exactly sure how it works. It may just kind of make the mast cells a little sleepier, is kind of the way that I think about it. But the Remibrutinib, what's really useful about it is that it doesn't matter if the needle gets there, even if however many needles get through, by taking that link out of the chain, the needles can't make the mast cell pop. That's really what makes it completely unique. It's the only treatment close in the pipeline that actually works inside the cell rather than trying to work on the surface of the cell. And so that does make a difference. But so again, the dupilumab sort of turns down the whole immune pathway that the mast cells are in. The remibrutinib doesn't affect that immune pathway, but it protects the mast cells from getting popped, so the needles aren't popping them anymore. The Xolair we already talked about is binding the needles and protecting the cells from getting hit by the needle in the first place. The last medication that we have that's the furthest away, and this one's probably, my bet would be 5 years before it's going to be available to prescribe for patients. It's new enough that I'm not good at saying the name yet. I think it's Barzolvolimab. But basically what it does, it binds to something called c-KIT. And c-KIT, for all intents and purposes, you could think of it as a little sort of marker on the outside of the mast cells that kind of says, hey, I'm a mast cell. So this barzolvolimab binds to the c-KIT, and it basically causes that mast cell to go away. It doesn't pop it. It just kind of makes it slowly die. And the mast cells really, you don't need them. At least we have no known, like you need mast cells for something. And so what it's doing, it's not going to get rid of all of your mast cells, but it's really reducing how many of them you have. And so that one is really just getting rid of the water balloons. And so probably when that one comes out in 5 years, it is going to be the most effective thing that we have. What the preliminary data shows us, that it might be that most people with urticaria, with CSU, it might make it go away completely. And the vast majority of them, it gets them dramatically better. And it may even be something where you take it for a while, then your mast cells get, you have many fewer of them, then you might be able to stop taking it. And it might be a long time before the urticaria comes back. And so that's a really exciting drug, but that one's still very preliminary. It's 5 years out, it might be 3 years, 4 years, but there's a lot of things that are going to happen as we learn more about it. It might turn out that the preliminary data wasn't reflective of what the real data is going to be, but that one's very exciting. Going to be an injection again, like the Xolair and the dupilumab, but probably going to be the most effective drug that we're going to have if the preliminary data pans out.
So the interesting thing is that with dupilumab and omalizumab, and even in the future with medications like remibrutinib, they will likely be indicated for multiple allergic conditions. And so picking the right patient for each therapy really is precision medicine in the sense that we are able to look at all of the other conditions that a patient has and then see that, this medication may also help with their asthma. It may also help with their eczema, or it may also help with their nasal polyps. So when we have medications that are approved for different conditions, or we have multiple medications that are approved for the same condition, trying to figure out which medication to use happens with shared decision making. And part of that shared decision making is, what other conditions does the patient have? Are they comfortable with needles? Are they not comfortable with needles? And would a daily medication work for them? Or would a monthly medication work for them better? So there's so many different things that we have to consider when we're looking at each of these medications.
So it sounds like every drug that you're talking about really addresses the mast cell in its own way.
Yes.
And I know that Dr. G's also used the analogy of a piñata for the mast cell and the histamine response, which I find a good one too.
I haven't heard that before. I like that.
Yeah, that one's a good one because you can imagine like the histamine as the candy and then the kids as the reaction, right? Like the craziness that happens once the piñata explodes. The last one, it lessens the amount of mast cells, but it doesn't completely destroy them. So you still have them circulating in your body. They're just not as plentiful.
Yes.
Okay.
That is exactly how I would put it.
So there's all this research with the drugs that are working on the mast cells. But I know that throughout this series, because this is the 6th part in our CSU series, yes, it's something autoimmune, but what it is, we can't really tell you. Do you know if there's research going on in that regard of just trying to figure out what's causing CSU?
Yes. We know there's 2 main types that we know of for CSU. One type is autoimmune, where you actually have antibodies, different types of antibodies. There's A, M, G, and E. G is like the main one. But so in autoimmune, there are type G antibodies, IgG, that are either directly activating the mast cells or are activating the IgE to activate the mast cells. Autoimmune, where your immune system is either sort of attacking the IgE or attacking the mast cells. Then there is not autoimmune, but autoallergic. And so with autoallergic, what that means, the IgE, which is what the needles that normally need to be activated, you have normal IgE, but the problem is the IgE is getting activated by something in your own body. Essentially, in that one, you're allergic to yourself. It's not that your immune system is attacking your mast cells. It is that your mast cells are getting activated because you're allergic to yourself. So we've got the autoimmune and the autoallergic are the 2 types that are well worked out. But still seems like there are other types of CSU, other mechanisms, and people are still looking to figure out what are those other mechanisms, because the autoimmune type we've known about for a long time. That was, almost 25 years ago when I was a dermatology resident. We already knew about the autoimmune type. The autoallergic type has been more recent that we figured out that type, but we think there are still other types, and people are looking. But it's really hard to figure this stuff out, like really, really hard. So people are still looking, but I haven't seen anything that makes me think, oh, okay, we're like right there. We're pretty sure that this type is happening too. There's nothing that I'm even to the point of like pretty sure.
Thank you so much, Matt. I feel like we've gone through so many different aspects of new treatments, where we're at with CSU. And we just really appreciate your time and for you giving us your expertise today.
Thanks, Payel. It has been a pleasure. Really fun talking to you guys about this. And I'm just really excited for what the patients have coming.
Great. Thank you.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.